Assalamu alaikum everyone. I am Muhammad Rihan, CEO AID, and we are with Professor Dr. Arshad Malik. We are going to host our third session of trigeminal neuralgia course on pathosis of trigeminal neuralgia. This session was distributed in 6 sessions basically, and after all the 6 sessions, there will be a quiz, and then there will be on the basis of that quiz, there will be certificates. And now I will like to ask Dr. Arshad to continue his third session of this course. And in the end, I will discuss how to get your certificate as well. Thank you so much, everyone.
Bismillahirrahmanirrahim. Can you hear me? Dr. Rehan, can you hear me? Can you hear me?
Yes, sir, I can hear you.
Dr. Rehan, can you hear me? Okay. Bismillahirrahmanirrahim, everyone. This is our third session has been completed, and we are our fourth, and that is pathophysiology of trigeminal. Ladies and gentlemen, after understanding trigeminal nerve, we have gone for the every aspect of the nerve and nerve pathophysiology. Having background of nerve and nerve condition, and that was the mechanism of orofacial pain. Now we are exactly prepared to understand the trigeminal neuralgia pathophysiology. In the previous lecture, I have covered the etiology of trigeminal neuralgia. The etiology was demyelinization and demyelinization of the myelinated fibers. Demyelinization myelinated, and these demyelinated are generally they are a delta fibers, and when they are demyelinated, alpha fiber also is sometimes demyelinated. That's why it results into trigeminal shocks of neuralgia. This is the etiology. But what is the pathophysiology? Why it happens? What are the different diseases which choose go for trigeminal neuralgia? Generally, it is called that generally it is called as that trigeminal neuralgia is by demyelinization.
I think there is some issue in connectivity, so kindly be patient and hope so Dr. Arshad will join us quickly. It is back.
So association of the pathosis with all the trigeminal neuralgia यार इसको दरवाजा बंद कर दो दानी को मेरे पास भेजो मैं कंप्लेन so arterial loop, slow growing brain tumor, slow growing brain tumor, acoustic neuroma, epidermoid cyst, fibrous band across the petrous ridges, glioma, idiopathic bone cavities, and intracranial trauma. Ladies and gentlemen, we will take step by step every disease. And that is, first is the multiple sclerosis. You see, this is a picture of the B lymphocyte, macrophage, mitochondria. B lymphocyte and macrophages are capable of secreting antibodies. And these antibodies, with the help of the cilia, which are just going there, and also that the phagocytosis of the macrophage is going on. And this macrophages, all these events results into multiple sclerosis. And this multiple sclerosis, actually, this results into trigeminal neuralgia. So in the young age, is a main cause of neuralgia. It actually, multiple sclerosis are there. It used to result into bilateral trigeminal neuralgia. But what is very special with this? The special with this is I again share with you that B lymphocyte and macrophages with microcilia in multiple result into these. These B lymphocyte and macrophages, they release antibodies and these effect on the myelin sheath. With the help of the macrophage, go for the phagocytosis, results into all sclerotic brain. And that is the disease when trigeminal used to occur in young age. And there is bilateral symptoms. The trigeminal neuralgia, whenever patients come to you, with a bilateral, what you say, bilateral trigeminal neuralgia symptoms, that is due to multiple sclerosis. There will be lack of trigger point always, and there is absence of reflective period, which is very mandatory in trigeminal neuralgia. And whenever you go for the that is the multiple sclerosis picture you see in the brain, and that is the part where multiple sclerosis has occurred. And these parts actually, when are present in the vicinity of trigeminal ganglion, you will find the multiple sclerosis result into demyelinization. And this myelinization, if it is in the area of the pons or at the peduncle of the base of the brain, it to hurt the trigeminal basic ganglion, and you are going to hold the all the episodes. The next we are going to see is the aberrant artery. You see, that is the basic loop of the petrosal artery, which is being in its way, it is just touching the area of the trigeminal at the base of the brain, and that's why it is hurting, and there may be demyelinization at this area. Now, next is aberrant arteries. These aberrant arteries have you seen in this, that this is the trigeminal nerve, and that is the basic artery passing on. And this area, you will see it is the area of compression, and that area of compression results into demyelinization of the trigeminal nerve, and patient is going to get the trigeminal neuralgia. Next, we move on to vascular malformation. This vascular malformation is very important. You see, this is the base of the brain. Here you see a AV formation, right? This whole AV malformation, it's near the vicinity of trigeminal nerve, and that is right. And if you the is right there, malformation, and that is the trigeminal nerve passing on, and it is going to the coming from the base and moving towards the ganglion. And there is our area where the vascular malformation has occurred. And this area may result into demyelinization of right here, this area. And any branch which is touching this area may get into demyelinization, and patient is going to get the vascular neuralgia. Now, we move to another impacted, that carotid siphon. It is very important to understand the carotid artery. Internal carotid artery basically is a very important part within the vicinity of trigeminal ganglia. You see, that is the vascular. Just here you see the intercarotid artery right here, and that is trigeminal nerve. And if you see by the CT scan, you will see a symphon here. And when you look at the dramatic interpretation, you will understand more. Here is the carotid canal. Here the internal carotid artery come inside the base of the brain. It is the middle cranial fossa, and it is moving like this. It has the C1, C2, C3, C4, C5, and C6. And the C6 and C5 and 4, these three areas, basically they are very important, that are in the vicinity of trigeminal ganglion. This is the base of the trigeminal ganglion. You are coming, this is V1 ophthalmic, this is V2, that is foramen rotundum, that is maxillary, and this that is the mandibular foramen ovale. Now, all these three things, that these three parts of internal carotid artery may abrade the surface of a trigeminal nerve anywhere, and they results into demyelinization. Now, next is the arterial loop. Arterial loops, sometimes they are present around the vicinity of the trigeminal nerves. You see, if you explore, this is the inferior cerebellar artery right there. This inferior cerebellar artery, you go on exploring it, you see just right in front of that is the fifth trigeminal nerve. And this, the just beside that is the nerve is placed on the vest, and it is pulsating. And when the nerve is pulsating, you find that this nerve will result into demyelinization. If you see at the picture, you see this is the trigeminal ganglion, where this is ophthalmic, this is maxillary, this is Gasserian ganglion, this is pons, and here it is coming. And you see the anterior and inferior cerebellar artery, they are just loop here. And when they make the loop surface of the trigeminal ganglion, they are going to hurt the surface of the trigeminal ganglion. That may result into demyelinization and the start of trigeminal neuralgia on that particular nerve. The next is foramina ovale, foramen rotundum. Foramen ovale is the where the mandibular nerve come out from the base of the brain, and foramen rotundum is that foramina from where axillary nerve come out from the base of the brain. Now, sometimes there's developmental anomalies, and that developmental anomaly is that this foramina ovale and foramen rotundum, they become narrow, such a Sorry, there is a problem of what is going on there, but we will handle it and be us, and inshallah we are going to handle it. So that is narrowing of the foramina, foramen ovale, and foramen root. Next is another important, and that is the slow growing brain tumors. There are so many brain tumors which are in with the vicinity of trigeminal nerve. These slow growing tumors are, this is a big slow growing tumor at the base of the brain, and it is in the vicinity of the caligus. Understand, this is the brain stem, then is the midbrain, and then is the pons. And in the vicinity of the pons, if there is any parasagittal, olfactory, cellular, and foramen magnum area is not so important as compared to this area, which is a vicinity near to the trigeminal ganglion. And if it is right there, then we are going to have the problem with reference to Gesserian ganglion pressure. Now, you see, this is the vicinity generative tumor, which is beside to your trigeminal nerve. And if the tumors are in this vicinity, they are going to press the trigeminal nerve. Beside to all the lesions of the tumor, you will get another accessory disease, and that is neuralgia. And beside the tumor has a brain problem with a headache, there's nausea, there's vomiting, there's a posture. There are so many things with the tumor of the brain. But side, you are going to have the problem with reference to the tumor in the trigeminal neuralgia within the brain. Now that is another picture of the chondroma, which is slowly growing on there in the vicinity of the clavus. And that is the problem which is going on there. Now next is acoustic neuroma. Before going to detail of the acoustic neuroma, try to understand the acoustic area. Acoustic area is this. Acoustic mean ear. Area, it is right here. And you see all the lesions which are developing in the vicinity of acoustic area, they are beside to trigeminal nerve and trigeminal ganglion. So what is going to happen? If this type of acoustic neuroma is right there in the vicinity of petrous area, you are going to get the nerve, because you see this is the stem and that is the nerve coming on, and this nerve is just beside this neuroma. So you are going to be hurt by this neuroma, and you are going to get the trigeminal neuralgia. Next is the epidermis. Although epidermis are very in brain, it is more the skin, even it is in the oral cavity, which we used to say single dermide and sublingual epidermoid cyst as well. So you see, this is the just a base of the brain, and you see this is the area the epidermoid cyst is present. And you just open and you will find that a big cyst is present within the brain. And this, if epidermis is right in the vicinity of the trigeminal basal ganglion or Gesserian ganglion or in the pons, you are going to get the, you see, if it is this vicinity, you are going to get the trigeminal neuralgia as well. And this is due to this epidermoid cyst. Next is the fibrous band across the petrous ridge. As I have described you, that the petrous part is that part which contains the internal ear, and over the surface of the this Peter path is the climbing of the trigeminal nerve. And from here is climb forward, come to the middle cranial fossa, where it lies right on the medial side and rest against the bone. This fibrous band right here, you see, this is the fibrous band. It is developmental anomaly, which is present just beside the nerve. And if it is present there, it is going to hurt the myelinated sheet of the trigeminal nerve, and you are going to get the trigeminal neuralgia. Next very important tumor is glioma. Although glioma is not generally found, in the vicinities of the trigeminal ganglion, but really there are few studies, few cases reported that this glioma is present sometime in the vicinity of the trigeminal basal ganglion, Gacerian ganglion, with reference to any of the branch, and that results into abrasion, or that results into pressure of the trigeminal nerve. Next very important thing, portine glioblastoma. Portine mean in the vicinity of ear or in vicinity of Peter's part. You see this tumor, it is right here. This Peter's part of temporal bone, which is contain the internal ear, and that is the portine blastoma. And this glioblastoma, actually, it is in the vicinity of right here is the nerve, and it is going to give the pressure of the trigeminal basic nerve. Next is the primary brain lymphoma, very rare disease, and disease with reference to giving pressure to the area of trigeminal nerve. You see, very less, but where it used to happen, it used to give the pressure to the brain. You see, this is the normal side, and that is going to give the pressure to the brain, and that is there. Now, next is tuberculoma. Tuberculosis or tuberculoma of the brain is not so you see, that is the area where tuberculoma is, and are separating it. But this brain tuberculoma is within the vicinity of trigeminal nerve, then you are being hurt by tuberculoma. The next is sarcoidosis, a rare disease with reference to these days, not reported much, but it results into amorphous protein deposition within the brain area, and that results in mutilation of the area of the brain and giving pressure to the area, especially in the vicinity of the trigeminal nerve if it is present within that area. And next is the very important to dental surgeons, and that is idiopathic jaw bone cavities. Ladies and gentlemen, dental surgeons generally do not look into x-rays and do not find the idiopathic bone cavities. These long-standing idiopathic bone cavities, basically, they generate the pressure. They produce the gases. They say nitrous oxide sometimes. Sometimes they say nitrous. It is produced there, and it exerts the pressure within the hollow cavity of the idiopathic bone. It may result into trauma, where it may result due to any loss of bone or developmental anomalies. These idiopathic bone, When there is any pressure generates within these bone cavities, it results in trigeminal neuralgia. These are the cavities which are generally available. And what you see, these are sclerosing, and these titles always. And there is no root resorption. There is proper lamina dura around, and it used to ovoid area. If you look at this whole area of the cone shape, and this cone end is right here. And this is idiopathic bone cavity. When you see, you want to cut it and open this idiopathic bone cavity area, you will find that there is absolute empty bone cavity. You will use the it, you find nothing inside, and that's the main reason that these idiopathic bone cavities sometimes exist within the mandible, and within the maxilla it is generally less, but it is more in the mandibular area, and that results into increase of the pressure in the vicinity of the trigeminal nerve. So what happens that due to this pressure, inferior alveolar nerve get pressurized, get demyelinization, and that is the basic problem that you are going to get the trigeminal neuralgia. The next is the and very important thing is intravenous trauma, and that is the thing we're going to discuss. This is our routine practice. You see, this is the accident, and by this accident don't mean, but when you open the cranial surface after this trauma, you find that on the meninges, you see how much big clot is there, and that clot is going to exert the pressure over the brain. You see, and this clot is giving pressure to the brain, and that is the basic thing which is exerting direct pressure at the base of the brain, and sometimes if it is given to the area of the trigeminal nerve, then it is going to give the demyelinization. These are the common pathosis of the trigeminal neuralgia, but certain very less common as well. Neuritis, syphilitic lesions. They are also sometimes into demyelinization of the nerves. Basal meningitis, due to inflammatory episode, there may be a pressure of inflammation and resulting into demyelinization. Portine diseases, because sometimes these diseases may result into demyelinization due to pressure. And due to pressure of portine disease, the AV formation is generally very common, and especially in the mandible, if the AV malformation is there, it is going to hurt the nerve bundle, and that results into demyelinization of the A delta fibers. TMD or trigeminal temporomandibular joint dysfunction syndrome, and we have gone for the full season where I have discussed with reference to the auriculotemporal nerve lesions and lesions of the inferior alveolar nerve, sometime with reference to that of trigeminal and temporomandibular joint diseases. Arteries of the circumvallus, if they are enlarged, especially in the old ages, especially with reference to hypertension, and especially with reference to vascular diseases. Arthritis of this area may result into this type of lesion which hurts the trigeminal nerve. Sarcoidosis is also one of the cause. Cavernous sinus thrombosis is generally used to occur due to oral lesion, sometimes due to ophthalmic vein. It used to take the oral all infectious lesion to the base of the brain where the coronal sinus is present, and that results into coronal sinus thrombosis. It is a big inflammatory and infectious disease, and it may result into inflammation of this area, and that inflammatory area may result into the pressure on the trigeminal ganglia. Lyme disease, rare, but it do hurt sometime to trigeminal nerve. Temporal arteritis is one of the differential diagnoses. When we talk of the DD of the trigeminal neuralgia, temporal arteritis is one of the, you have to take the pulsating area over the temple area, inflammatory region, and sometimes you have to take the biopsy of this temporal arteritis, and you have to go for the angiogram to get the exact vicinity of temporal arteritis. So ladies and gentlemen, today our topic was pathosis with reference to trigeminal neuralgia only, and that is very precisely we have evaluated all the basal tumor, all the different lesion, traumatic lesion, different inflammatory lesions, different lesion which give exert pressure to the trigeminal area, and that we have studied in detail. Ladies and gentlemen, here we end our today's session, and if you have any question, you can freely ask me, and you can raise the hand, and it is over to the Rehan. It is over to you, boy. Yeah, Dr. Rehan, it to you.
So I explained
Any question you can ask.
I think, Dr. Arshad, there is no question left. Is my voice audible, Dr. Arshad? Dr. Arshad, my voice is audible or not? All right. I think it is audible. Fine.